I'll be talking about the Presbyopic IPCL tonight. Tonight we'll just talk about the reasoning for the Presbyopic IPCL. The design has been covered quite nicely by Dr. Yip and Dr. Ania. Assessments we'll go through a little bit more to add on to what Dr. Ania has shared. And I'll also share our outcomes, the primary and secondary outcomes, as well as a discussion and troubleshooting. All right, so why consider the option for Presbyopic IPCL? Now, we do know that as cataract refractive surgeons, and probably many of you, if you are a budding refractive surgeon, the grail is always presbyopia correction. Now, traditionally we have two different options. We have laser vision correction and also clear lens extraction, or RLE. But now comes the problem when we have the problems with laser vision correction are the growing number of pre-cataract presbyopic patients who are keen for spectacle independence, and patients who are unsuitable for laser vision correction, for example, thin corneas, suspicious floats, etc. And most of the time you do find that if you're correcting them with LVC, mini monovision is not good enough. And while presbyopic ablation is becoming increasing more in popularity, it tends to be capital intensive, and there tends to be some problems as well with slow recovery, especially with surface ablation. So the arguments, on the other hand, you have clear lens extraction or RLE, and there's a perceived notion that clear lens extraction is actually a one-way street, and this potentially deprives younger patients of improving IOL technology. And this is something that I tend to adhere to quite, and I personally feel for very strongly. And many of us know that when patients come in with axial lengths of 28, 29, 30 mm, you have limited trifocal or presbyopic options for these eyes. Another pertinent argument against a clear lens extraction in these younger patients is the concern regarding the risk of retinal tears and detachments. It's probably been more and more clear recently that patients who are high myopes, more than -10, especially patients who have not had a PVD yet, patients who are under 50, for example, the cumulative RRD risk does double in patients with an RLE. These patients, non-PVD patients, high myopes, the cumulative RRD risk triples actually in these patients compared to patients who have not had clear lens extraction or RLE. So there's this idea that the younger the patient with high myopia without PVD, the higher the risk of RRD, and this is still an idea that's under review by the ESCRS, and we're waiting for the studies of the MyPred, the results of the MyPred study. So we have, on one hand, we have LVC, which is capital intensive. It's probably not the most cost efficient option. On the other hand, you have RLE and CLE with the increased risk of possible retinal problems in younger patients. So is there another option? The question is actually whether there's a reasonable third alternative, and my objective tonight is not to try and convince you one way or the other, but to actually share my experience with the Presbyopic IPCL and to see whether you decide that it may be a useful addition to your practice. So unlike the US elections where you have either this guy or this guy, in this case, the Presbyopic IPCL, after implanting it for the past couple of years, 3 years, I find that it's been a useful addition to my practice. All right. So the design for the Presbyopic IPCL it's actually a diffractive design. It's 3.5 millimeter design, whereby the apodized steps where the light energy is focused, progressively shifted from the far point to the near point across the pupil. Is essentially a trifocal design, and as you can see here on the bottom left, this is our defocus curve that we presented in 2023 during the IPCL masterclass. You can see the three peaks approximating to well-known trifocal IOLs on the market. Okay, and so the arguments for the Presbyopic IPCL, again, excellent range, as Ania and Dr. Yip have covered. especially for the monofocal designs, if you're talking about glare and halos after LVC, there is ample evidence to note that monofocal IPCLs, monofocal phakic lenses, actually induce a lot lower HOAs post-op in the region of 0.089 spherical aberration. Whereas if you look at the center, that's our topographic guided PRK induced spherical aberration, which is actually a lot higher than what's reported with phakic lenses. So there's more importantly also the very pertinent argument against RLE and CLE in younger patients with no PVD, potential for retinal detachments, and that's the third very cogent argument that we usually have that usually goes through my mind. All right, so assessments similar to Dr. Ania. As what Dr. Ania has shared, we go through the whole list. Apologies once again. We go through the whole list, and I think for new surgeons who are keen to start, it sounds like we're throwing a whole list of things that you need to do, but essentially what you need to do is use whatever machine that you have, whether it's a Scheimpflug camera, whether it's a SSOCT, whether it's a Placido disc, and start implanting using that. Track your volts and keep your data, and then you know more or less how to adjust the sizing. For example, I found that digital calipers in my practice approximate our Scheimpflug camera in the past when we've been using the Galilei G4, and currently we're using a swept source OCT from Heidelberg, and the digital caliper actually approximates these two machines very well. On the other hand, our Aladdin from Topcon actually measures about 0.2 mm smaller, white to white. But we found that our SSOCT and the Scheimpflug cameras actually do approximate the digital caliper quite well. If you're using Placido, no problem. All you need to know is that you need to upsize, make sure that your lens is not undersized with the Placido if you find that it is during the first few implantations. So we've implanted for the past 2-3 years. We've done about 26 eyes so far. It's not a big sample size, but it's enough to garner quite a lot of insight. Okay, so we've done 14 patients. Two patients had unilateral implantation, and our target were ametropic, and the outcomes we measured at 3 to 6 months. Now, the important thing to understand about my cohort was many of them were not normal patients. Many of them were amblyopic, about 40% were amblyopic. Many of them had staphylomas, and for example, we had a patient who was measuring about -2 SIL refraction, but his cornea was -11 diopters of cornea astigmatism. So you can see these are the sort of patients that are being. So when we go through the results, please keep this context in mind. So these were the demographics. 26 eyes, men and women, both equal, almost equal. The mean sphere was -7, ±3.58. But we had 1 or 2 outliers, about 13 to 16. Mean cylinder was a little bit lower, 1, but -1 ±1 diopter. And the mean AQD was 3.19. So our patients had AQDs on the deeper side. The white to white, which we use a swept source OCT, was 12.19 ±0.45. And I think most importantly here, this is the parameter that I track, is the white to white IPCL difference, because this tends to be what I base a lot of my sizing on. All right, so these are the standard graphs from the JCRS. Efficacy, when we look at the uncorrected DVA, our cumulative Snellen VA, we're getting about 73%, achieving 7.5. 100% of eyes achieve 612 or better. Next slide, please. Post-operative uncorrected distance visual acuity versus the pre-op CDVA. So we can see that our post-op uncorrected distance visual acuity, 42% of of patients had UDBA of 1 to 3 lines worse than the pre-op CDBA, and these were primarily due to residual refractive error. But about 58% of eyes actually achieved what their UDBA was equivalent or better compared to the pre-op CDBA. All right, and most important thing, the safety graph showed that no eyes lost lines. Okay, four eyes actually gained 1 line or more. So to us, this was actually quite happy and quite heartening. All right, so spherical equivalent, 73% were within 0.5 diopters and 96% were within 1 diopter. We have an outlier there, right at the bottom there, but this was a patient who was intentionally undercorrected, -2 diopters. On refraction, she was happy, she was a -13. She was happy with a -11. She did not want a -13 correction, so we intentionally left her -2 down. And we did a laser vision correction for the other eye, which was actually a lot lower. Next slide. All right, near vision, I think this is what everyone's interested in. Okay, so 88% of our eyes achieved at least N6 uncorrected near visual acuity. This is at 40 centimeters. All right, and 100% achieved at least N9. If you're looking for N4, it's a little bit, you know, the proportion is only about 15% uncorrected. The red line, the red is the pre-op corrected near visual acuity. All right. Okay, and so when we're looking at the uncorrected near visual acuity post-op, a few eyes lost lines. Again, this is due to, we think it's the residual refractive error. And when we look at the safety graph, now this, we did have a couple of eyes, 2 eyes that actually lost 1 line or more. So 1 eye lost 1 line, 1 eye lost 2 lines, and we'll explain what we think was the problem later. Next slide, please. All right, so secondary outcomes. We're looking at the volts. We're looking at the rotational stability, the IOP at about 3 to 6 months, whenever was the latest, and other complications such as cataract. All right, so the volts, we are right on target. You can see here our volts were 640 microns, which is right in the range, right in the middle of the range, which is recommended by the manufacturer. So we had 1 or 2 a little bit on the higher side, we had 1 or 2 on the lower side, but by and large, by sticking to our white to white IPCL difference, our volts have been quite consistent so far. Rotational stability, we've had 2 eyes that actually rotated post-op, one about 90 degrees, but these were because of lower volts, and this patient actually had a white to white IPCL difference of only about 0.4 mm. So if you remember just now, our white to white IPCL mean difference was about 6.66 mm. So for us, we've upsized him 2 sizes, and so far it seems all right. Okay, so the pressure, now the good thing about, and I need to actually correct Dr. Yip just now, the patients that I've had angle closure with in the past were from another manufacturer. And that's one of the main reasons why I switched over to IPCL. Once I switched over to IPCL because of the more gradual sizing options, I've not had any shallow chambers at all. And this is not hyperbole. I mean, all my complications are out there on the screen to see, but I've not had any patients with angle closure. Like I mentioned, we've had 2 eyes with low volt and rotation, but in terms of shallowing of the angle, no. All right, so secondary outcomes. So we polled our patients, as many as we could. We don't have many, but we managed to poll about 5. And these included the patients with cataract and residual refractive error. You can see here we asked the patients we polled the patients and we asked them to indicate the amount of difficulty they have in performing different near tasks such as books, reading labels, text on their phone, and intermediate vision such as their computer vision. And we asked them to indicate then how satisfied they are with their near vision. And we can see that satisfaction with near vision, 20% were completely satisfied. This is a small poll, so this was 1 patient. and 4 patients were either very satisfied or moderately satisfied, and patients in the moderately satisfied category had residual refractive error and mild anterior subcapsular cataract. All right, so to recap, we have a small sample. It's probably not representative of the entire population, but it's enough to gain some valuable insights. So some discussion and troubleshooting. I think post-op, the main problem that we had in terms of reduced uncorrected distance visual acuity and near visual acuity post-op were residual refractive error. Now, the cohort of patients that most of you and most of us are likely to start implanting these lenses in are patients who have multiple problems. First of all, they're presbyopic. They have no accommodation left. These are patients who are highly myopic and they tend to have macular issues, epiretinal membranes. Some may have macular schisis. And if you can see, these are patients who had residual refractive error. You can see that the contour of the retina of the posterior segment, they're staphylomatous eyes. So first of all, we deemed that 40% of eyes were amblyopic before surgery, in that we couldn't best correct them to 6/6. And we also believe that, we've had 1 or 2 patients where we don't know where the refractive error is coming from. We've double-checked, triple-checked. What we do is, patients with residual refractive error, first of all, we make sure that the corneal topography is accurate. We look at the TCP, if you have the total corneal power, because you want to know where the axis is, because that should approximate the axis on the lens when it's produced. We've looked at things like the centration. We've looked at the angle kappa in some patients to try and find out where the problem is. But again, in 1 or 2 patients, we just didn't know. Short of full eye barometry, I think we put it down to an irregular retinal contour, as well as the fact that they're amblyopic and the subjective refraction will be up and down. All right, so rotation. So the lenses that rotated again significantly post-operatively were on the smaller side. They're about 0.45 mm difference between the lens and white to white, whereas our mean was about 0.66. So this is definitely going to be machine dependent. So the important thing is, I think, is to use what you're comfortable with. Start with something. The idea is to just start and examine. Use a digital caliper and see if you can approximate the size of lens that you need. When it's in post-op, just check the volts, collect your data, and take it from there. Then make the adjustments as you go along. But try and stick to one single measuring device. And the other thing is also back to sizing, please. The other thing is also, because I've not had angle closure with these lenses, personally I think that it's not an issue sizing up rather than sizing down. So if you're concerned, I think at least for my practice, if you're concerned about whether the sizing is accurate, I would rather err on the larger side, especially if the AQD is big enough, rather than downsize. Next slide, please. All right, let's address the elephant in the room, cataract. So we do know that cataract, especially anterior subcapsular cataracts, do occur after ICL implantation. The literature is clear, and these are recent systematic reviews from 2016. Then there's another one, this is 2022, and there's another one in 2016. So the risk of anterior subcapsular cataract does increase with increasing age, smaller volts, and if it's early, may be related to surgical trauma. We do know that the volts actually do decrease as the years go by. So someone with an already very low volt post-op, you have to watch them very closely, because there is a real chance that that volt may start to become smaller and smaller year by year. Yeah, I think the important thing to understand is also that the cataracts that we've had were deemed to be not visually significant, in that we could still fully correct them for distance. So we've opted to just leave them alone. Patients have been informed. And I think and my patients were actually most likely from surgical trauma. The way the lens unfolds is because it unfolds towards the capsule, and there's sometimes a very slight brush of the unfolding lens along the capsule. So what I've been doing now, I've filled the chamber a little bit more than I usually do, than when I first started. You don't overfill, don't overpressurize the eye, because that causes iris prolapse. And iris prolapse during ICL surgery is a nightmare. So fill a little bit more than what we've been told by the manufacturer to inject OVD and leave the OVD in strings. They can actually see the visible strings. But I tend to fill a little bit more until the mass of OVD is a little bit more confluent. And I know I've spaced out the chamber a little bit. And what I've taken to do is I've taken to angle the lens, the barrel upwards. Now you may feel that may cause the lens to come and hit the endothelium. But what I've noticed, at least in my hands, is that the lens doesn't come straight up that way. When it comes out, the barrel actually goes horizontal. So even though your barrel is probably a 45, in my hands at least, the lens comes out level. And I'm not sure whether it's something Dr. Anya and Dr. Yip have noticed, but I mean, we can cover that later. So I found that the lens delivers at a 180-degree angle, regardless of where I angle the barrel. So rather than angle it down towards the lens capsule, I just lift it up a little. All right, so pearls and tips. Accurate, consistent refraction is key, but I think, importantly, I think most budding surgeons would be, you're shooting for perfection, but in patients like these, a lot of the time you don't achieve perfection. What you can do is, we can get close enough that the quality of life improves significantly, that's a big plus. All right, so if you can, accurate, consistent refraction is key. Usually you achieve this better in younger patients without macular issues, without amblyopia, without high astigmatism, and be prepared for refractive surprises in this subgroup of patients. I've just ordered another lens for a patient with macular schisis. He didn't want retinal, he didn't want lens extraction because he was concerned about retinal issues. But these are patients that you actually need to preempt them and say, look, we can probably get you 80 to 90% of the way. Are you happy with that? Can you accept that? If they can, then by all means go ahead. You've disclosed the risk, you've disclosed the potential for a poorer outcome. Don't overpromise. These are fantastic lenses. This is a great addition to any refractive surgeon's armamentarium, but we do need to temper both our expectations and patients' expectations. All right, so have a lower threshold for refining the lens position. One of the patients who had residual astigmatism was a patient with -3 SIL. And sometimes I'm just lazy to rotate the lens intra-op, and sometimes if it's just 5 degrees off, with lower cylinders, that has a negligible effect on the final refractive outcome. But sometimes if the patient's uncomfortable, it's a little bit legit to, because sometimes when you've removed all the OVD, and the lens just, after you remove the final amount of OVD, and then the lens just kind of tilts back again into the off-rotated position, to fill the eye with OVD again, and to tuck it back in again, and to remove all the OVD is a little bit time-consuming. So higher cylinders have a little bit of a lower threshold for doing that. And if comfortable, fill the OVD a little bit more. That's what I found personally, but of course don't over-pressurize the eye. All right, so conclusion. I think at least for my practice, I found it's available. It's a low capital cost addition to my armamentarium. In general, it delivers excellent, satisfactory presbyopic correction. And I think the limitations that sometimes we see in outcomes such as these are because we're starting from quite a poor position in terms of visual potential already. All right, so I think the prevailing sentiment is a lot of us, when we are starting to implant something like this, there's always a little bit of fear of not getting a 6/6 and a very happy patient the next day. But you have to start somewhere, and it's even with results that many people would say, look, there are complications. I'm still persisting and I'm still enjoying implanting these lenses because they actually fill a very valuable niche. Thank you very much.